we can start taking some questions.
Great to see you, Dr. Das, and absolutely happy to answer all the questions.
I'm just looking, there's the first question, I think was about the Empower 1.0 abstract that I had reviewed, looking at adjuvant treatment with atezolizumab, which is a PD-L1 antibody. I think what it's, one of the questions being asked is, how long do you do adjuvant immunotherapy for, and is there a select patient population that's really felt to benefit most from this? I think this is a good question. I think, we're still awaiting additional data, of course, and longer term follow-up. What I was able to share with you is the disease-free survival that was presented at ASCO this year. Of course, we're waiting to see if there's an overall survival benefit with the addition of atezolizumab. And as far as trying to really identify the patients that are most likely benefiting, I think that we still don't really know. We don't, what we saw is that all patients with stage 2 and 3A disease did seem to benefit regardless of PD-L1 expression levels, though we did see higher or increased benefit in those patients who are PD-L1 positive. So I think as far as the subgroups that are most likely to benefit, I think there's a hint of the PD-L1 expressors actually deriving more benefit from the adjuvant atezolizumab. In the trial, the adjuvant atezolizumab was continued for 16 cycles. And so, I think the optimal therapy or the optimal amount, to offer to patients, I think, all we can go by is really what was done in the trial, which was 16 cycles. And it's similar more or less to the durvalumab in the Pacific trial, which was continued for a year.
Now, great answer, Dr. Das. And this was 16 cycles on a Q2-week basis, right? Because atezo could be, yes, it could be 2 or 3 or 4 weeks, but that's an important issue. And of course, you have to look out for toxicity as well, that we are all painfully aware of. Majority of times you don't get those toxicities, but when you do get those toxicities, they can be quite real.
Absolutely.
One of the questions I was asked, we'll go back and forth, and of course, was that in terms of did the authors find reluctance on the part of African-American patients to enroll in clinical trials? Diversity and enrolling onto clinical trials is incredibly crucial for all of us. And we're painfully realizing that indeed not all ancestries or ethnicities are being enrolled into the trials. And that's what the authors and the presenters actually pointed out, was that there was much less enrollment into clinical trials by African Americans. And we have to make a huge difference. And at the same time, it is important to be culturally sensitive to how we offer these clinical trials. And those are all ongoing evaluations from all of us here in the nation and throughout the world to be able to incorporate all of the patients for clinical trials to make a huge difference.
Absolutely. Let's see, I think there's another question. So there's a couple of questions about the Checkmate 816 trial, which was the trial looking at nivolumab, the PD-1 antibody, in combination with chemotherapy as neoadjuvant treatment. There was a question about whether the path CR rate was affected by PD-L1 level in any stage. The abstract that I really focused on was really looking at the surgical outcomes. And if I recall, the data that we have so far with the PATH-CR rates, we're seeing PATH-CR rates, high PATH-CR rates, regardless of PD-L1 status. And I think that there's a question also about what the chemotherapy was in that trial. And yeah, it was a little bit, it's easy to miss because it was in the really small text on the study design, but essentially in that, I'm just pulling it up right now, in the non-squamous patients received either cisplatin pemetrexed or carboplatin paclitaxel. In the squamous patients, they received cisplatin gemcitabine or carboplatin paclitaxel, or cis-vinorelbine, cis-docetaxel, or cis-gemcitabine. So there were a number of different chemo regimens that were used in this trial. And I think really regardless of the regimen that was used, the addition of nivolumab did significantly improve the pathologic CR rates really across patients. And that was really seen regardless of PD-L1 status.
Great, thank you.
And I think the question of whether we would do this in clinical practice comes up a lot. I mean, I don't know about you, Ravi, but I think although this is very compelling data, we don't yet know that the path CR rates are going to translate into survival benefit. So I don't think many of us are actually doing this in clinical practice outside of a clinical trial.
Completely agree, Millie, is that if we can enroll patients onto clinical trials and if we can await the FDA approval, and we worry a lot about the payers, right? Will payers pay for these kinds of regimens unless they are approved? And so let us wait, but I think some of these will become approved in a very short period of time. So we're looking forward to that, but at the same time, you still have to practice the standard oncology practice that we all have.
Yeah.
One of the questions, Millie, that I had was, what is the option for KRAS exon 2 PG, the G12V mutation that can occur? And I didn't necessarily talk about the KRAS mutations, but there are a number of KRAS mutations that can occur. And so you can have it in codon 12 or codon 30, codon 13 or codon 61. And how we treat them is becoming a differential. So of course, G12C sotorasib has been approved in second line type of setting, and that is being utilized. The adagrasib did get a breakthrough, but it is not approved yet. And so we're awaiting the Mirati drug. So sotorasib is the Amgen drug, Mirati drug is the adagrasib. We're awaiting that as well. And so that's for G12C. However, for G12V, the jury is still out because there are a number of clinical trials that are ongoing. For example, Veristem has a trial. There is a pan-KRAS inhibition in terms of the BI drug. But at the same time, we know that potentially chemotherapy and immunotherapy can work for KRAS mutations. And certainly you have to be cognizant of the PD-L1 expression. And if the PD-L1 expression is high or over 50%, or equal to 50%, then you can do single agent therapy as well in terms of immunotherapy, such as pembrolizumab or cemiplimab. So those are all important issues to consider. But if people can consider enrolling patients like G12V or G12D or G13 onto clinical trials, and there are a number of them across the nation and across the world, it's not a bad idea.
Agree. I just had a question for you, Ravi. Have you used sotorasib yet in a patient with G12?
Yeah.
It's just because it was approved just a few months ago.
Exactly. So sotorasib, we were part of the phase 1. Our colleague, Dr. Marwan Faqih, was the second co-author for the New England Journal of Medicine paper that was published. And then, of course, the phase 2 was published recently in the New England Journal. So we have a lot of experience with sotorasib. And it is effective, and certainly it's in the second line setting. I think we have to see how important it will be in the first line setting as well. So those are all trials one should think about, and or combination therapies. Can one combine sotorasib with, let's say, chemotherapy or with immunotherapy? And those are all ongoing trials at this moment in time. But very much looking forward to more drugs being approved in this space, and very much unneeded space, unneeded in terms of the what we have. But at the end of the day, we are so excited that these combinations may even work better. The last one I talked a little bit about was the SHP2. So there are these downstream signaling pathways from KRAS, and it's a phosphatase called SHP2, and therapies combined with SHP2 with KRAS may become important as well. So have you seen, I come back to you, Millie, with respect to what you said a little bit earlier, and how should one determine what type of immunotherapy one should use? Those are all important questions, be it in early stage or be it in late stage. Do you go with Pembro or Nivo or Atezo? And how does your institution, or we should all think about that?
Yeah, that's a great question. We know that these drugs all work very similarly. Many of us have probably mean, Nivo, of course, was the first approved in lung cancer. And then, of course, shortly after that was the Pembro approvals. I think many of us are just more familiar with using pembrolizumab single agent or in combination with chemotherapy in our patients with newly diagnosed disease. And, we have approvals there, of course, in combination with chemo, regardless of PD-L1 status. One of the questions is, in our high expressors of PD-L1, what do we use Pembro single agent, or do we use the Ipi-Nivo combination? I personally, still am using pembrolizumab single agent. Of course, you mentioned cemiplimab's also approved, atezolizumab's also approved. So we have a number of different options. None of these have been compared head to head. And I think a lot of it really comes down to what you're most familiar with. Of course, if you have clinical pathways at your institution, which drugs are kind of favored within the formulary. I think those are all, of course, important considerations. But in my clinical practice, I've been mostly going with pembrolizumab single agent in the high expressors. Patients who are really symptomatic or have high tumor burden, I'll go with Pembro plus chemotherapy, even for the high expressors.
I like that. And, the added caveat to this is it also depends on how we have contracts with the various payers, the various insurance companies, because it is so crucial for all of us to think about the guidelines, no question about that. And a lot of us also use pathways as well. But then at the end of the day, what will be supported by the insurance company, because these can be very expensive drugs themselves. And one can imagine single agent immunotherapy by itself can be expensive, but then when you combine it with chemotherapy, it can be a little bit more expensive. And then, of course, as the other regimen, the quadruplet regimen, such as, for example, the carboplatin, let's say Abraxane with atezolizumab, with bevacizumab for metastatic disease, potentially that can be incredibly expensive. So how that all plays into our equation is important as well.
Yeah, and I think it's tough because we just, we don't yet really know that there's one regimen that's really works the best, which is why we have so many different options now. And, in the Ipi-Nivo combination, I think it's the same, you can make the same argument. It's sort of double checkpoint, basically dual immunotherapy. Obviously, costs are going to be higher than single agent immunotherapy. We don't really know that that's superior to our single agent options. And we also know that there's a higher rate of immune-related adverse events with the combination of CTLA-4 inhibitors and PD-1, PD-L1 antibodies.
And, people have to be aware, I agree completely, is that these side effects are interesting and amazing, and we have to put on our internal medicine hat at all times, right? So obviously one could see hypophysitis, thyroiditis is very common, but pneumonitis or hepatitis or nephritis or colitis. And we've even seen blood disorders as well. So you can even have autoimmune neutropenia. We've also seen, for example, hypereosinophilia. So all of those play into role for us. And the more immunotherapy we give, the more experience we get, and the more of these quote unquote, what was touted as rare side effects, we're seeing more and more of. And it's important to keep that in mind.
Yeah. And of course, the ones I worry about, and I think all of us who use these drugs in clinical practice have also seen patients who've developed pretty severe pneumonitis, myocarditis, and those are the ones, of course, that can be really fatal, and so it's just I always kind of keep it in the back of my mind. It's very challenging to counsel patients about all of the possible autoimmune conditions that can occur. I mean, thankfully, most of them are very much treatable with steroids. Really early recognition is the key, and early initiation of steroids. But in some cases, despite our best efforts, patients will develop very, very severe autoimmune side effects. And I think one of the main areas of investigation is, one is, of course, trying to really evaluate which patients are most likely to benefit outside of PD-L1, which patients are most likely to benefit from these drugs. And number two, having seeing a patient in the clinic, being able to predict if they're going to be one of the ones to develop, one of the autoimmune side effects. I think that would be really incredible if we were able to have that to help inform some of our risk-benefit discussions with our patients.
Absolutely. And I think one of the questions to you and to me also becomes, Millie, and I'll have you speak first, is that are there biomarker criteria that you use for neoadjuvant or adjuvant therapy for early stage? And then I'll answer in the context of late stage.
Mhm. I mean, for early stage, we don't really have any right now. So of course, we don't have an approval yet for immunotherapy in either the neoadjuvant or adjuvant setting. And I mentioned that I think that the data, the disease-free survival data for Empower 010 is quite compelling, and many of us do feel that the FDA may end up approving this drug. I think in the end, the question is this drug going to get approved for a certain subset of patients? Namely, is it going to be restricted to PD-L1 expressing, patients who have PD-L1 expressing tumors? I don't think we know that yet. And so certainly right now, we don't have a criteria. PD-L1 is really kind of our best biomarker that we have, although there's a lot of interest in trying to look at other biomarkers. I think we still feel that patients with driver mutations really derive less benefit. We saw that in the Empower 010 trial too, where there's really sort of less benefit for those ALK positive patients. And so I would certainly think twice about using these drugs in patients with EGFR and ALK, really regardless of PD-L1 status. And I think we still need to learn more. And hopefully, as we get additional information and longer term follow-up from some of these studies, we'll have a better understanding of the patients most likely to benefit.
Great. Would you comment a little bit more about, so suppose they turn out to be EGFR mutated positive, early stage disease. Yeah. Do you strongly support the ADAURA trial? And then should you think about immunotherapy in that context?
Yeah, I'm glad you brought that up. And, of course, last year's ASCO ADAURA made a big splash, and we got an FDA approval for osimertinib as part of adjuvant therapy in our early stage resected EGFR positive patients. That happened in December 2020. And so we are having these conversations with our early stage EGFR patients. Yeah, those are not patients I would be offering neoadjuvant or adjuvant immunotherapy to for a number of different reasons, but especially now with the FDA approval of osimertinib as an adjuvant treatment option for these patients. This is something I'm talking to my patients about. I don't think it replaces adjuvant chemotherapy, so I still would recommend cisplatin-based adjuvant chemotherapy for early stage resected EGFR patients. And then upon completion of the adjuvant chemotherapy, I think that certainly the patients with stage 2 and 3 disease, they really seem to benefit the most from receiving the osimertinib. And so I'll have a discussion. There are just some patients who really don't want to continue on, additional therapy, don't want to deal with, the potential side effects, although they're not, with osimertinib, they're not as, pronounced as what we see with some of our other drugs. I think that, it's still a pill you have to take for a number of years. And so I think it really becomes an individual discussion with our patients. But I am having that discussion. We do have an approval for osimertinib in our EGFR patients in the adjuvant setting. And so for a 1B patient, I think I feel less strongly about offering it, but again, would have the discussion.
That's great. And we as well at our institution, we believe, both you and I see a lot of EGFR mutated patients, early stage even, and we like the ADAURA data, and we appreciate that it's disease-free survival. And of course, overall survival will take a little bit longer to mature, but absolutely it's a great option for our patients. And so totally agree. And then in terms of how we think about the biomarkers and how long to continue the immunotherapy for metastatic disease, certainly PD-L1 is an important biomarker. And the most common PD-L1 biomarker is this 22C3, and that's the one for pembrolizumab, but it can be used potentially for others as well. But then you have the 28A as an example for nivolumab, but we don't necessarily use that, but in other tumors you do. So it depends on the institution. It depends on how you work together with your pathologist and work out the biomarkers. And tumor mutational burden is also important. So we look at TMB, now having these liquid biopsies and assessing the TMB, that does help us making a decision. And clearly for us, we have to have an algorithm within our practice to be able to say, we would use this first, depending on this biomarker, and then we would use that second. And so it is crucial for all of us to define what would be the ideal setting for our patients in the clinical setting that we see them in. The other thing is that one of the questions was the optimal duration of this IO in metastatic disease. So we tend to do it for about 2 years, unless there's a problem or unless there's an issue. If there, let's say, severe toxicity that arises, then potentially you have to stop the therapy. But we're also finding that even after stopping the therapy, that the survival outcome is turning out to be pretty good. And of course, it's not great, but it's not bad as compared to what we used to do in our clinical practice. So I think it's an important one to continue with the IO for about 2 years or so. The last question I had here for now was it's not the last question, but at least one of this is, when do you introduce Infleximab or Vadillosumab for IO-induced diarrhea? Do you wait for GI to suggest? Do you keep patients on steroids when they're on Infleximab? So this is the art of dealing with side effects from immunotherapy themselves. There are a lot of guidelines that are available, for example, ASCO guidelines, SITC guidelines that we tend to utilize, but we immediately get our gastroenterologists involved. And what's important too is that you should have a colonoscopy at least, if one could do it, and then a biopsy as well to be able to look at this. And I think any one of those options are reasonable as long as you're working together with your gastroenterologist. And I think that's mine, but I wonder if I can comment a little bit more on this next question, Millie, if that's okay. It's
Absolutely.
the in leptomeningeal disease, EGFR mutated lung cancer on osimertinib, after 2.5 years of getting extracranial diseases, now responding to double dose osimertinib. Any feel for avantamab, lazertinib using when high dose osimertinib fails? Unfortunately for all of us, Millie, myself, and everyone in medical oncology, we're seeing a larger number of leptomeningeal disease in our patients, especially with the EGFR mutated population. Even though, for example, osimertinib does cross the blood-brain barrier, it has been effective, but this LMD or leptomeningeal disease, not very clear as to what what therapy would work. I think you have to get your neurologist and neurosurgeon involved too. You know, if there's let's say a hydrocephalus or an NPH, you might have to have a VP shunt. That's important. And at the same time, double dose osimertinib we do use based on the previous data as well. So instead of 80 milligram, 160 milligram once a day is reasonable. In the old days, we used to do pulse dose erlotinib, and in the old days as well, and sometimes I still do that, is we combine, for example, erlotinib with temozolomide that we had published previously as well for leptomeningeal disease. Intrathecal therapy, not really clear it works that well, except there is now data coming out that was just published from China in phase 2 setting, where intrathecal pemetrexed has been utilized now as well. So we're going to be doing that. We haven't done that for our patients, but I think keep that in mind. And at the same time, you know, can avantamab and lazertinib also cross the blood-brain barrier, help us in the leptomeningeal disease? I think we're looking forward to that. Not all the data is in, and certainly that's something that we have to pay attention to, is either using that doublet combination and then developing LMD, or LMD has developed and then using that doublet combination. And so to be determined, but it's very clear from all of us that when leptomeningeal disease does develop, you should try to see if you can sequence that out like in a next-gen sequencing, but that's hard in a cytology specimen. But one can send off to a certain company for cell-free DNA in the CSF. That has actually helped us for a few patients themselves, and then try to design the therapy. Well, what do you do in your practice for these leptomeningeal disease patients, Millie?
Yeah, this is it's a really a devastating complication that we're seeing. And as our patients with EGFR are living longer, I think we're seeing a higher incidence of leptomeningeal disease. Yes, I agree with you. I think this is very much a co-management with our neurology or neuro-oncology colleagues, and to try to figure out what the best approach would be. I too tend to sort of shy away from intrathecal chemotherapy. We were doing that for some time years ago. I think now that we have the double dose osimertinib option, many of us are doing that. And I agree that that's probably my first thing that I would do. in a patient, whether or not they were on the lower dose, the 80 milligrams. If they were on that, I would just double up and see if we can get better CNS penetration with a higher dosage. And there are some patients who respond very well to that. Others who really don't. You make an attempt with that and they don't respond. And then we tend to go. So if this is a patient who's progressing on 80 or 160 milligrams of osimertinib, I tend to go with chemotherapy. So we know that pemetrexed does cross the blood-brain barrier. These are patients also, I would add Avastin. So, the carbo-pemetrexed Avastin regimen, I think is one that I use more frequently in these patients. I mean, it's something that we use, regardless of LM disease or not, patients who've progressed on osimertinib. I think chemotherapy is really our standard, but particularly addition of Avastin to pemetrexed, trying to get that extra CNS effect. We do have a number of clinical trials as well, trying to look to see whether there's better therapies that are, more specific to leptomeningeal disease, and talk to our radiation colleagues as well about, sometimes just making the diagnosis, of course, on an MRI. I actually just saw a patient last week where it was a finding on an MRI scan. The patient was asymptomatic, and and the recommendation was to send the patient to get a lumbar puncture to confirm. And of course, we know that the sensitivity is not great. It's about 50%, for lumbar punctures. And so, what do you do in these patients who have leptomeningeal findings on an MRI? You don't really, or are not able to confirm it on an LP, and then they're asymptomatic. I would tend to just, watch and continue my current therapy and get very, continued close surveillance imaging. I think LM disease comes in many different flavors. Of course, the patients who are symptomatic, it can be very, very challenging. And thankfully, I think the double dose of osimertinib has been effective for a lot of our patients, and we have some IV chemo options as well.
Absolutely. And we look out for any toxicities, and especially like thrombocytopenia that can occur with this kind of double dosaging. And then, of course, the rash and the diarrhea, but that can be managed pretty well in most of our practices. And it, it brings us back to that point about tumor heterogeneity, right? What might have arisen in the lung as, let's say, an L858R mutation, let's say in exon 21 for EGFR, but then in the CSF, you could potentially have not only L858R, but you could have some other concomitant mutation as well. And so you have to look out to say, if, for example, there's MET amplification along with that, then can you add a MET drug in combination? So all of those things are coming to fruition. And we can't emphasize enough that anytime you have progression, you should think about a biopsy, you should think about cell-free DNA, you should think about molecular analysis, next-gen sequencing. And one of the things I should say is that we're becoming more and more convinced that it's not only about the genetic changes, but there are these non-genetic mechanisms that can occur. And so let's say EMT, or epithelial mesenchymal transitions. And how do you overcome that as well is going to be important in our therapeutic decision making. I think we have one more question, Millie, is can you comment on cryoablation in lung cancer?
Yeah, I think so. This is a technique that's usually performed by our interventional radiology colleagues. As we're seeing our IR colleagues getting more familiar with cryoablation, I think it's great to have them involved in our tumor boards. So there's the cryoablation. I think that it's not suitable for every type of lung tumor. I think it's always very helpful to speak with our IR colleagues, specifically for patients where it may be a peripheral lesion that's kind of easily accessible and amenable to cryoablation. I think our standard, and I think part of it depends on the use. I mean, if you have a kind of an early stage patient that you want to treat with curative intent, of course, the standard is still surgery, or for non-surgical candidates or high-risk surgical candidates, SBRT. Cryoablation is another option, though I don't think that we have as robust data with cryoablation compared to SBRT, and so I think we're not using it in that type of curative setting. I've had a few patients who've had local recurrence after SBRT, and we talk to our colleagues about this option, though I think frankly, it can be quite challenging to perform cryoablation in a previously irradiated region. And so these are definitely discussions that we're having in a multidisciplinary setting where we have our radiation oncologists, our interventional radiologists, and we're really trying to look at the imaging, looking at the clinical scenario. I do think that we're using it more often these days. I don't think that it's kind of routine. I'm curious, Ravi, at your institution, how cryoablation comes into place in your practice.
Yeah, I agree completely with you. It's a multidisciplinary effort, and it's an individualized effort too, depending on if, let's say, radiofrequency ablation or cryoablation can play a role. Even sometimes could proton beam, proton therapy play a role in that setting as well. So all of those we tend to individualize. The tough issue is there are no randomized trials to help us, right? And so it's just N of one kind of, oh, in my experience, I've done this, or I've seen this happen and this terrible thing happen. I don't think we can do that per se, and we do need more trials to be able to help us with that. I know it's actually almost, we have one more minute, but I just wanted to have some last thoughts from you and me. I wanted to say, lung cancer, we've come a long way, and it's amazing what's being done I talked a little bit about metastatic disease today. Amazing, we're seeing cures even in the metastatic disease setting. We're seeing such long-term outcomes for our patients, and it's fantastic. And I wanted to thank all of our patients and their families. And as some of you know, today is World Lung Cancer Day. And so we appreciate our patients and families, and thank you, Millie, for what you do. Thank you to all the healthcare providers, what they do, and of course, our patients and families. So thank you very much. Millie, your last thoughts?
Thank you, Ravi. I think that was a wonderful wrap up of, yes, we couldn't have made any of this progress without our patients and their caregivers. And we are very much indebted to them each and every day. And so, I think we still, as medical oncologists, have a lot of hope. We've just seen in a very short amount of time the amount of progress that we've been able to make, and we're all looking forward to continued progress in this field. And it's really wonderful to see these, to see our patients with metastatic disease living years out, and not just living, but living well. And that's really the goal. And so we're all very excited as we continue to think about how we can improve upon our current outcomes for our patients. And so it's really wonderful to be part of this. And thank you. It was really a pleasure to be here with all of you. And thank you so much.
Thank you all. Bye.